Good afternoon, everyone. Welcome to today's SVS VQI Smoking Cessation webinar series. My name is Jennifer Correa. I'm the marketing manager at the SVS PSO. I'm joined today by Betsy Weimer, SVS PSO Director of Quality. Before I turn things over to Betsy, I do want to cover just a few brief housekeeping items. We will be keeping all lines muted throughout today's presentation, but please type any questions you may have in the Zoom Q&A box. For this smoking cessation series, we will not be answering questions live during the event. Instead, we ask that you have any questions that you may have, type them in the Q&A box, and we will be creating a frequently asked questions document. This document will be updated following each smoking cessation webinar and posted on the VQI website, along with the recordings and slides from each session. And with that, I will turn things over to you, Betsy.
Thanks, Jen. Welcome, everybody, and happy Tuesday. We'll go ahead and get started. Again, as we have these webinars, I do like to read the disclosure and disclaimer here. So the National Quality Initiative Smoking Cessation webinar series is based on my knowledge from taking and passing the CTTS certification course. Each state, province, and continent is unique and offers their own individualized smoking cessation resources. Insurance reimbursements also vary state to state as well as internationally, and the NQI Smoking Cessation webinar series is intended to provide a variety of resources and knowledge for VQI participants, but not replace expert opinion or treatment for individual patients. All right, so within the Smoking Cessation webinar series, we have monthly webinars, there's recordings, slides, resources, and as Jen's shared, a monthly FAQ document. There's also a dedicated area on the VQI website that you can get to, and just below that is the hyperlink to that. So here are our dates, the topics, and the various audience. So today we're going to be doing the pharmacotherapy. Here are the topics that are expanded. And again, just what I shared, we're going to be doing pharmacotherapy statistics. So the past 2 months, we talked about historical background and also cigarettes and e-cigarettes and their difference. So as I shared the past couple of months, each monthly webinar, kind of like stepping stones, so they build upon each other. So you may hear just a couple sentences or a few key words each month. And again, these are just the stepping stones. And here's the additional topics, just, expanded a little bit more. So let's begin our journey for today. So 3 drugs that are currently used as the first-line pharmacotherapy for smoking cessation. Those are nicotine replacement therapy, or you'll hear the NRT, bupropion, and varenicline. Pharmacotherapy plus patient motivation doubles smoking cessation. 30% of smokers use medications, but only 5% use behavioral interventions. Pharmacotherapy can be used on all patients unless it's medically indicated. So there's also the 5 A's of smoking cessation. So you ask, what do you smoke? How much do you smoke? And how long have you smoked? Then you advise. You discuss the harmful effects and the urge for the patient to quit. You assess, what is their willingness to quit? Then you assist. You help create a best plan for quitting. And then you arrange. You follow up, and then if they're quitting, within 1 week of the quit date. And there's various types of follow-up. And again, those will be shared later on. So, quick fact. How do you calculate pack years? And you may not even know what pack years are. So pack years are a unit used to quantify the cumulative amount of cigarette smoking that a person has consumed over their lifetime. Whoops, sorry about that. And the answer is the pack years equals the number of packs divided by the day times, divided by the day, times the number of years smoked. So for example, if a person smokes 1 pack per day for 20 years, their pack year total would be 20 pack years. So 1 pack per day times 20 years equals 20 pack years. And this is important in learning how to determine what medicine and how much medicine to prescribe for a patient. So this is how the most important thing that you'll want to know is calculating pack years. So let's talk about some statistics. One cigarette is equivalent to approximately 1 or 1.5 milligrams of nicotine that's absorbed systemically. One pack of cigarettes has approximately 20 cigarettes or 20 milligrams of nicotine. One can of smokeless tobacco is equivalent to 4 packs of cigarettes or 80 milligrams of nicotine. E-cigarettes are actually advertised as a percentage. Usually 5% is equivalent to 41.3 milligrams of nicotine. So the e-cigarettes, if they're advertised as 5%, that's almost that's a little over 2 packs of cigarettes. So think of it that way. And again, last month we talked about there being over 500 types of e-cigarettes. So, little example, 1 pack of cigarettes, again, has 20 milligrams of nicotine or 20 cigarettes. 1 Juul pod is approximately 41.3 milligrams of nicotine or 41 cigarettes. 1 puff bar or an elf bar, that's usually about 300 puffs, has approximately 50 milligrams of nicotine or 50 cigarettes. And then 1 Surin pod has 200 puffs. This is approximately 90 milligrams of nicotine or 90 cigarettes. A few more statistics. A single hookah, excuse me, and you can have little hookahs. This is just your average hookah size. That is like smoking 20 cigarettes an hour, which is a pack. So 1 pack in an hour. A cigar has 20 milligrams of nicotine, and a cigar is considered a cylinder of tobacco wrapped leaves. A cigarillo contains 3 milligrams of nicotine. A little cigar contains 1 to 1.5 milligrams of nicotine, so the same as a cigarette. Cigar smokers have a higher risk of aortic aneurysm, lung cancer, heart disease, oral cancer, and throat cancer. And as many of you may know or have seen firsthand, cigar use has actually steadily increased since 1993. A lot of people have encouraged cigar smoking with wine bars, so that has steadily increased. So now let's talk about over-the-counter versus prescription medications. So your over-the-counter medications are your nicotine patch. Typically, they come in a 7, 14, 21 milligram with a 24-hour delivery. You match the dosage to the patient, whatever they're used to smoking, to decrease their withdrawal. You can use more than 1 patch at a time, and that is only for those that smoke more than 1 pack per day. Also over the counter is nicotine gum. It usually comes in 2 and 4 milligrams. The nicotine lozenge is also over the counter. As far as prescriptions, you have the nicotine nasal spray. At one time, you had a nicotine oral inhaler. They stopped carrying that as of August of 2023. It was very addicting. And then you have your bupropion SR, and then your varenicline. So we're going to dive a little bit deeper into each of these. So your nicotine patch has a long release at a high level. It takes 6 to 8 hours to reach its peak, its cutaneous absorption. You want to apply it to a hairless, usually upper extremity daily, or you can make sure it's from the waist up. You want to rotate your sites. You change it the same time every day. Why do you do that? Because you want to make sure you get all of the medication within that patch. You want to make sure you remove the old patch. And 50% of patients actually experience a skin rash and or irritation, but you can actually use hydrocortisone cream if the physician recommends that. Side effects of a nicotine patch are nausea, headache, dizziness, and insomnia. So a few precautions for the nicotine patch. Medication adjustment consideration for those patients that are on insulin, that have asthma, those that are on antidepressants, antipsychotics, theophylline, beta blockers, and alpha blockers. You also want to be aware of those with allergies to adhesive tape, of course, because you got the patch, you're sticking it on their skin, because it has potential for your rash, skin irritation. Those with recent heart attacks, those with any irregular heartbeats or angina, and also those with severe renal and hepatic dysfunctions. Nicotine gum. Now, actually, you think about the gum, you think it's easy, but actually there's a very poor compliance at just 32%. The absorption is affected by a patient's pH. You want to tell them or remind them to avoid coffee, juice, and soda, and not to eat or drink at least 15 minutes before or while using. It is convenient, it is flexible, it's easy to chew, they just park it in their cheek. It is immediate and sustained with a 15 to 20-minute peak. They do have a delay in weight gain. You can titrate it for withdrawal. It is inexpensive and obviously over the counter, and it can be used in combination with other therapy. You do want to be cautious for those with TMJ. And here's a interesting fact. The use of Tagamet specifically may increase nicotine concentration. There's just a picture of the gum. Also for nicotine gum, patients are instructed to chew the gum until they get a peppery taste, and then that's when they put it in their cheek. And that's what they call to park it. The dosing, please consult the physician. This is just simply a guideline. You can get this off the package, when you walk into a store. But week 1 through 6, you usually do a piece of gum every 1 to 2 hours for a max of 24 pieces per day. In week 7 and 9, you do a piece of gum every 2 to 4 hours with a max of 24 pieces a day. And then week 10 to 12, you do a piece of gum every 4 to 8 hours, max 24 pieces a day. You prescribe 2 milligrams for those that have the desire to smoke greater than 30 minutes after waking. And you do a 4 milligram dosing for those that have a desire to smoke less than 30 minutes after waking. Just want to remind everybody that the Europeans have a different, and they have a higher dosing than the United States. They actually use 6 milligram dosing. But again, this is simply a guideline. You can get this on the back of the gum right when you go into any pharmacy or drugstore. Again, this is just a simple guideline and example, just to kind of get you to understand the various types of prescriptions and different things that are out there for patients. You also have the nicotine lozenge. And again, this is just a simple picture you can find anywhere at any drugstore. So the lozenge is absorbed quicker than gum. It's 15 to 20-minute peak time. Again, it has a delay in weight gain. Again, a reminder, don't eat or drink 15 minutes before. Now, the max on this is 20 lozenges per day. The gum was 24 pieces. The lozenge is 20. And again, the dosing is very similar to the nicotine gum. Again, since it's over the counter, you can read about it in your local pharmacy. The side effects of a lozenge are hiccups, nausea, and heartburn. Excuse me. You do not want to chew a lozenge, and you do not want to swallow it, because you will get a very big burst, apparently. It can be used in combination with other therapies. And then for our prescription therapy, insurance, I just want to remind people, insurance does not always cover prescriptions. Encourage patients to contact quit lines. There are several federal and state resources. Some of these even have free resources. Make sure you can instruct patients on how to research, or, excuse me, do your research and help them understand. And currently, medications are approved for cigarette smokers only. not for e-cigarettes. So I just want to remind people of that. Nicotine nasal spray. 1 to 2 doses per hour. 1 dose equals 2 sprays, 1 in each nostril. Make sure you consult a clinician for dosing. But how they do the nasal spray, they prime the bottle, they blow the nose, tilt the head, breathe through the mouth, they spray each nostril, and they tell patients to not sniff or inhale. And when I say prime the spray bottle, you don't spray it in the air, you actually spray it in the tissue. Side effects are irritation, watery eyes, sneezing, coughing. Do not drink within 5 minutes of using. Unfortunately, 94% of patients do have some side effects of irritation, but it's worse at the beginning, but it does decrease to about 81% after 3 weeks of use. Nicotine absorption is fast. This is actually the fastest route, as you would probably assume with the nasal spray. It does have a high dependence rate, though. There is an increase in rhinitis, sinusitis, nasal polyps, and severe reactive disease for using this over longer periods of time. It can be used with other therapies as well. And unfortunately, it is expensive. So if patients are having to pay for this out of pocket, it can become expensive. So bupropion SR, this is usually, it's also known as Wellbutrin. It's an antidepressant. So the SR dosage is 150 milligrams. Now, you can use the XL dosing, which is the 300 milligrams. This is considered off-label, but it is used for smoking cessation. Again, make sure you consult the clinician for dosing. You want to encourage patients to decrease caffeine and other stimulants. This does decrease the seizure threshold. It can affect sleep. So you want to make sure you schedule meds earlier rather than later. Usually this is administered every 8 hours. The advantage, it's very inexpensive. This is actually one of the cheapest therapy. It's a pill. You just have to remember to take a pill. The adherence is good, and there's a delay in weight gain. A few disadvantages. There are precautions. There's contraindications. It does have increased seizures. There was at one time a boxed warning that actually has come off. You can have suicide ideations and neuropsychiatric problems with mental health issues. It can be used with other therapies. My computer's happy today. It's jumping. Sorry about that. And then we have varenicline. Now, this was once also, you could have it in Chantix, but Chantix was actually removed in 2021. So now everything is in the generic form. Again, consult the clinician for the proper dosing. The advantage, it is again, it's most effective. It's a pill. It decreases cravings. It decreases withdrawal. And again, there's a delay in weight gain. The disadvantage, there is severe nausea. So they always say take after dinner. Don't take on an empty stomach. They even say make sure you drink a full glass of water. And in the worst case scenarios, they do say that you can ask your clinician to possibly consider adding a anti-nausea medication. So that is one thing that you can consider. Some patients get hypersensitive to this. They can have a skin rash. When you dose them, make sure their renal function is monitored. Another disadvantage, if they have a pre-existing psych illness, you want to monitor that. If they have a seizure disorder and a history of alcohol abuse, it actually decreases their tolerance to varenicline. And then the side effects, nausea, headache, sleepwalking. Sleepwalking is a big one for varenicline. A lot of patients aren't aware of that. And angioedema. Smokeless tobacco. So chewing tobacco, loose leaves, braided leaves, which are called a twist, compressed leaves, which are called a plug. And then you have snuff. It can be dry or moist. A finely ground tobacco. This was something I was not aware of. It's called snus. And this is a moist snuff that is originated in Sweden. It's sold loose or in a powder. And then you have dissolvable tobacco. It's powdered tobacco that's pressed into shapes. And these are either sticks or strips. When I took this class, I've never been a smoker, I will admit that. So I did learn, but this kind of blew my mind. I did not realize all of this. I do want to remind you that heat does not burn tobacco products. Heat releases the nicotine and the chemicals. It's not the same as e-cigarettes. So just keep that in mind. Smokeless tobacco, again, 1 can is equivalent to the nicotine of 4 packs of cigarettes or 80 milligrams of nicotine. The harmful effects: oral cancer, esophageal cancer, pancreatic cancer. Then the specific oral effects. So a snuff pouch will cause leukoplakia lesions, increased carious mucosal lesions due to the high sugar content. I did not realize how much sugar is in smokeless tobacco. Recessed gingival tissue, and then abrasive tooth structure, a loss of alveolar bone. And maybe you might recall, or if you feel like it, you can go to webinar number 2, where I shared lots of pictures of the oral effects of cigarette and e-cigarette smoking. Smokeless tobacco also causes increased coronary artery disease, hypertension. Pregnancy, you can have early delivery, even stillbirth. And again, that was just a picture of some smokeless tobacco. And there's the snus, the one thing that I was not aware of. Now, there are substitute smokeless tobaccos that do help with smoking cessation. So one thing that we want to do is provide, again, cessation advice, support, and education materials. And again, consult a clinician for the dosing of the nicotine patch, which is one recommended therapy for smokeless tobacco. And also, again, like I just shared, there are substitute therapies. I'm going to show you one right now. This is called the back off example of substitute smokeless tobacco product. I actually found this recently in Walmart. And also they sell it on Amazon. It was just, I couldn't believe it. Anyway, so again, this is just a guideline. You can read it on the back of the back off examples. Again, I went into Walmart and was just looking, just to see what they had. So week 1, you get a blend of a 10% substitute and 90% tobacco. Week 2, you get a blend of 20% substitute and 80% tobacco. Week 3, you get a blend of 30% substitute and 70% tobacco. The main thing I want to tell you is you always have to allow for a minimum of 1 week blend. So again, this is just an example of a substitute smokeless tobacco. And then that's what it actually looks like. Fine cut back off original. And it comes in flavors as well. So again, that was just a quick sample. So our NRT review, side effects, the patch, and these are the most common. So I just wanted to kind of highlight. I know we've already spoken about all of this, but these are just a quick slide on the commonalities of these. So a patch, 50% of patients experience skin irritation and sleep disturbance. So nicotine gum, you get throat, mouth irritation, hiccups, GI upset, and jaw ache. For the lozenge, again, throat and mouth irritation, hiccups, and GI upset. Your nasal spray, nasal irritation, ocular irritation, tearing, sneezing, and cough. Your precautions for those: for patch, gum, lozenge, and nasal spray, monitor those with cardiovascular disease, especially those that with less than 2 weeks have had an MI, that have experienced angina or arrhythmias. Make sure you watch for the pregnancy population and also adolescents. And then precautions and contraindications for bupropion, seizure disorder, eating disorder, patients on Mayos within the last 14 days. And for varenicline, especially those with renal impairment and dialysis. So that was just a quick little review. Always speak with the clinician regarding questions on dosing or appropriate treatment. For nicotine withdrawal, and again, I shared this on one of the past 2 webinars, it takes 7 to 10 seconds for inhaled nicotine to reach the brain. You get increased heart rate, it improves your concentration and task performance, you get decreased stress and anxiety, and it induces stimulation and pleasure because of that whole dopamine effect that we discussed. Then you get the withdrawal symptoms: anxiety, irritability, anger, insomnia, decreased heart rate, difficult concentration, headache, nausea, weight gain, depression. These are things that our patients go through. And then the duration of the withdrawal. Symptoms of withdrawal appear within hours of the last cigarette. It peaks in the first few days and lasts for weeks. This is what they're going through. Think about their mindset. Then the symptoms may persist for months. Can you imagine? The ritual of smoking cigarette may last longer than physiological dependency. Behavioral therapies have been proven to help smokers. 12 weeks to 6 months is the quote unquote golden time frame for smoking cessation. But keep in mind, it may take others longer or a shorter time frame. So just imagine this whenever you're talking to a smoker. It is a nasty habit. It is a disease, but you really have to think about them, what they're going through, their symptoms, their duration of all of this that they're going through. So what is the appropriate treatment? Well, there is no perfect treatment guideline. Each patient is unique. They may require single therapy. It may be a combination therapy, more than one medication. Remember, behavioral therapy in combination with medication is evidence-based proven to increase and improve smoking cessation. We need to help educate and inform patients. And remember, this is a disease, a habit. 70% want to quit, and it may take several attempts to quit. The average number of attempts it takes to finally quit smoking is 6. That's the magic number. So support your patient and your clinicians. Share education, tools, and resources on smoking cessation. Having support truly does matter. And then the last topic, strength of evidence. Reliability and quality of the evidence supporting a particular recommendation or intervention is what the strength of evidence is. And I'm only going to talk about A, B, or C, and that's kind of the strength of evidence. So A is a strong evidence base, often based on consistent and good quality patient-oriented evidence, such as multiple high-quality studies. B is moderate evidence base, based on at least one high-quality study or multiple moderate quality studies. C is a limited evidence base, based on at least one study of moderate quality or consensus, usual practice opinion, disease-oriented evidence, or case series. A couple of examples. Proactive telephone counseling, group, and individual counseling formats are effective in smoking cessation. So that is an A type of strength of evidence. All clinicians should advise patients to quit smoking. That is also an A type of strength of evidence. Everyone should be asked about smoking. This includes all smoking, vaping, marijuana, etc., progress, and quitting. That is also a type A. Tailored educational materials are effective. This is considered a B. Why, do you ask? Think about it. Certain educational materials are written at a higher level. Some of our patients are very low socioeconomical population. They don't understand. Therefore, the evidence has proven this is not high on our strength of evidence. We need to work on that. We truly do. So this is considered a B. All patients who receive intervention should be reassessed at completion and subsequent follow-ups. This is actually a C. Now, you would think this would be an A, however, follow-ups don't always happen. Therefore, we don't have the evidence at this time to show that the follow-ups are completed. Therefore, we don't know if the patients who receive interventions have actually, had smoking cessation and or actually have even been reassessed. There's, not enough evidence at this time. So this is considered a type C strength of evidence. So again, these are just examples that were given to me in my certification course that just kind of make you stop and think and realize, the type of education that we need to do to make sure that our patients and clinicians have in order to assist with smoking cessation. Combination counseling and medications are more effective than medication alone. Yes, that has been proven to be a type A strength of evidence. And then I just have a couple of questions to kind of review with you. Which of the following are available over the counter? Nicotine patch, your lozenge, and your gum. Question 2. A 5% Juul e-cigarette has how many milligrams of nicotine? And that is actually 41.3 milligrams. Evidence-based tobacco cessation pharmacotherapy and counseling can double cessation rates for the patient who is motivated to quit. That is true. Question 4. Select the appropriate number of cigarettes in a pack with the approximate milligrams of nicotine that is absorbed systemically. And that is 20 milligrams. In one pack of cigarettes, there are 20 cigarettes and 20 milligrams of nicotine. Assisting a tobacco user in the 5 A's would likely involve, remember, these are the 5 A's. And again, assisting would be counseling and recommending an appropriate pharmacotherapy. And then one more question on the 5 A's. So the 5 A's recommended by the U.S. Department of Health and Human Services, Public Health Service, are used to assess and counsel individuals who use tobacco. And then just ask you to select the correct order. This is kind of a tongue twister, so I'll just go ahead and help you here. Ask, advise, assess, assist, and arrange. Question 7. A Sorin pod contains how many milligrams of nicotine? And that's 90. Question 8. A puff bar or Hyde e-cigarette contain how many milligrams of nicotine? And that's 50. A cigarella is a short, narrow cigar and not meant to be inhaled, but rather puffed and held in the back of the throat. A cigarillo contains how many milligrams of nicotine? And that is 3. Patients should be advised to not drink or eat acidic food or beverages within 15 minutes of nicotine gum or lozenge use, as it will decrease the amount of nicotine absorbed through the oral mucosa. And that is true. Select the nicotine replacement therapy with the quickest absorption rate. And of those 3, it's the nicotine nasal spray. And then here are a few resources for you that will be posted. And also, as always, if you have any questions about today's webinar, don't hesitate to reach out to me. And again, we will have a list of frequently asked questions and answers that will be compiled and available after this webinar that will be ready for you to see and be ready with the recording and the slides today. So thank you. I apologize. I went 5 minutes over. Hope everyone has a great day. Thank you so much. Take care.